Thank you for the introduction. I'm going to talk today about rehabilitation of severe and profound hearing loss. And I was going through Twitter just a few minutes ago and I saw this, in science, the lies are stored in citations. Whenever I give talks like these to an academic audience, I'm always like super self-conscious because what I'm doing, what I try to do is merge my experience with science. And a lot of the stories that I will tell in here are, yes, they are part of my experience, but I always shape them by the research that I think is important and what's lacking and what needs to be driving the field. Today, I'm going to talk to you about the impact of hearing loss, let you become familiar with cochlear implants, and understand why hearing assistive technology is insufficient to improve the outcomes of people with hearing loss. Over the last few years, we've come to realize that hearing loss is not just a sensory deficit. It has more consequences than people just saying, huh. It has significant consequences for health. A child with mild hearing loss in just one ear has twice the risk of failing a grade. Untreated hearing loss is associated with $22,000 more spent per decade on healthcare. It's the #1 modifiable risk factor for dementia, accounting for probably between 1% and 9% of dementia cases. It's associated with falls, cardiovascular disease, increased length of hospital stay, readmission, and ED presentations. Hearing loss is also associated with loneliness, and the loneliness associated with hearing loss has more consequences than smoking 15 cigarettes a day in terms of mortality. This loneliness is probably what underlies the depression and anxiety that then drives dementia. I don't think that there's like organic causes of hearing loss, organic contributions from brain changes with hearing loss resulting in dementia. The delivery of hearing healthcare in America is really quite abysmal. Only 20% of people who need hearing aids get them. Only 5% of people who need cochlear implants get them. If you are deaf, you have half the rate of employment and half the income of normal hearing people. So what we're going to focus on today is the rehabilitation of people who do not benefit from hearing aids. Is everyone in here familiar with a cochlear implant? I'm just curious. No? So what these devices are is basically an electrode that bypasses the damaged hair cells in the cochlea and directly stimulates the spiral ganglion of the cochlea. The electrode is under the control of a receiver that is subcutaneous, just under the skin here, and is hooked up to an external processor. The external processor digitizes sound, sends it up to the antenna, which then sends the signal across to the computer inside the head. The receiver decodes the signal and fires anywhere from 8 to 100,000 pulses per second. Remember that even though this is a cochlear implant, you actually hear with your brain. It's the brain that's doing all the work, all the rehabilitation, and that's what we focus on. This is an audiogram. What we do, the result that we get when we play the tones and get a map of people's hearing loss. On the top axis, you see frequency or pitch increasing from the left low pitch and to the right, becoming higher and higher pitch as you get to the consonant sounds. On the y-axis, loudness increases as you go down. The only point I want to make from this is that when cochlear implants first started 40 years ago, came into clinical practice, we implanted the profound of profoundly deaf people. And this means that people who could, if you had a chainsaw right next to them, they wouldn't be able to hear that. Over the last 40 years, we've realized that people do better if they have more residual hearing. There's more neuronal survival, both at the cochlea and at the higher tracts in the brain. So now we can implant adults with normal to severe hearing loss. We now implant pediatric patients under 12 months of age. Earlier is generally better in producing superior speech and language outcomes. We also know that patients who are single-sided deaf can fuse electric hearing and acoustic hearing into one signal and get benefits of hearing and noise and localization. So no matter what the audiogram, the common points are that people have usually severe to profound hearing loss in the higher frequencies, and they have a very poor word understanding, usually less than 60% on monosyllabic words. And this does not improve with hearing aids. I'm not going to go into much detail about the cochlear implant surgery. On this image right here, this is a view of the right ear. The skull base is on the left, anterior is top, posterior is bottom. You're looking through the facial recess. Let's see here, if my mouse goes here. So this is the facial nerve coming down here. This is the chorda tympani and the posterior canal wall right here. This is the incus buttress, and this is the horizontal semicircular canal right here. The electrode goes into the round window of the cochlea, which is kind of cool because we used to just punch a hole in the cochlea with the cochleostomy and a drill. Now we do softer surgery techniques by opening up the round window and preserving hearing in the structures. So after surgery, patients get their device activated a couple of weeks later. Depending on the type of patients, they go through auditory rehabilitation. Pretty much with adults who are cognitively intact, you can just give them an implant and they'll just go off into the world and they will passively incorporate the information, learn how to use it over the next year. If you are a pediatric patient, meaning prelingually deaf, hearing loss comes on before you learn language, it is extremely important that children be able to learn to listen and talk, that they go through very structured rehab over a period of years. They have to be taught to decode the signal. You'll hear sound simulations and understand why in a few minutes. Typical outcomes with cochlear implants, most patients can identify environmental sounds. Speech and quiet, most patients can understand around 80% in quiet. That drops by about half when you get into like a quiet restaurant noise. Almost half of patients can talk on the telephone. Music is not something that is generally appreciated in the manner of normal hearing people. When normal hearing people listen to music, it is to me, when I hear their descriptions, it is an act of escapism. I mean, like it's art that fills the body and the mind. That's not what I would say that music is for any cochlear implant patient. It's something that requires intellectual interpretation, association of the music with some event in life or whatnot. Patients with cochlear implants can localize sound, but you don't get a very fine localization of like where normal hearing people is like, I hear the sound and it's right out there, like a 3D representation in space. It's more like, I can tell it came from that direction. I have no idea what the azimuth is. Cochlear implants can help patients modulate their speech both in volume and in clarity. And quality of life generally increases with a cochlear implant. But this is a counterintuitive point that I want you to hold in mind as you hear me relate my story. The quality of life with an implant, or even hearing aids, this is very well studied, is never associated with how well someone hears with the device. We actually can't even point out what drives the quality of life. On the prior slide, I showed you some of the typical outcomes. The problem with implants is they are extremely variable. If a patient comes to me, I can tell them at baseline, it's extremely unlikely that I will make your hearing worse. You may lose all of your residual hearing with a cochlear implant, but the electric hearing that you gain should not make it worse. If you look up, you're looking up here at an article in JAMA, which is one of the main articles to justify pediatric cochlear implantation. And the only thing I want you to take home is just look at the middle graph. You can see the mean trajectory of normal hearing and speech and language outcomes over years, and then depressed is the cochlear implant group. The thing I want you to take home is it's extremely variable. There are things that affect outcome like duration of deafness, residual hearing, and prior auditory experience, plus or minus how old you are when you get your implant. For kids, family involvement, auditory training, consistency of device use are important. Variables that don't really affect outcome are the different devices offered on the market or the number of functional electrodes that you have. So now I'm going to shift into telling you my story and why I think we need more than just technology to improve the outcomes for deaf and hard of hearing people. The first time I ever saw a cochlear implant surgery was about 15 years ago, actually at UW, where I was doing a research fellowship. The patient was a 4-year-old boy, and he's born with hearing loss so severe that even the most powerful hearing aids is not going to give him a chance to develop normal oral spoken language. After the surgery, the electrodes curled up inside our ears deliver about 100,000 precisely arranged pulses, and our hearing will go from something that sounds like this.
Life is a grand adventure or nothing at all.
Much quieter, though. To something that sounds like this.
Life is a grand adventure or nothing at all.
Life is a grand adventure or nothing at all, Helen Keller. So if you think about that, those 100,000 precisely arranged pulses will allow that child's auditory cortex to develop and solely from that input and provide him a chance to learn to listen and talk. And when I saw that surgery, I basically just teared up right there, didn't tell anyone. I'd been deaf since birth, like this child, but I did not get my cochlear implant until about 21 years later, when I was 21. And I teared up because I thought this child would never experience the debilitating social isolation that occurs when you can only talk to one other person, that he would not miss the punchline to every joke and be told, never mind, it's not important, when he asked for something to be repeated. He would never know what it's like to be unable to chime in at a dinner party because he couldn't hear his friends. And he would not matriculate into a professional school only to have the chancellor overrule the acceptance of the admissions committee just because he was deaf. I teared up because I thought that we really had reached the zenith of possibilities for deaf people. But I was wrong. I didn't really think about this when I started out my training, but before me, no other deaf person has successfully gone through a surgical residency program with cochlear implants. I applied to ENT residency programs during medical school. It took about 30 interviews over 2 years, a second 2-year research fellowship, and an extra year of internship before I was able to convince my field that I could take care of a critical airway in the middle of the night. That left a scar that was pretty deep, pretty wide. When I had applied, I'd already done the 2-year Howard Hughes Fellowship. I had published on the far right of the bell curve. I had spoken to several heads of state about hearing loss. And on the side, I taught myself electrical engineering to create a hearing aid to help me hear in the operating room. I had done all of these things out of pure passion. But when I was on interviews, instead of hearing, wow, you have some drive, it would be great to have you on our team, I was greeted with, so, you're the deaf boy everyone's been talking about. And I sat on the sidelines and watched my colleagues with similar credentials get into the top programs. Before this point, I had never thought of myself as different, disabled, or the target of bias. In a really cool turn of events, I was actually recruited to the residency program at Indiana University. Dr. Richard Miyamoto was a pioneer of pediatric cochlear implantation. In contrast to the research fellowship that I did at UW, where we focused on the bottom-up ways of restoring signal coding in the hearing nerve, at Indiana University, we were looking at how the top-down processes are changed. And you're going to see in the next couple of slides how that really makes a good background for understanding how to intervene in hearing loss. As I got into surgical training, I became profoundly aware of the limitations of cochlear implants. These limitations are not obvious and can really torpedo a deaf person's desire to succeed in the upper echelons of professional society. I was determined to overcome this problem, and you're going to hear with some sound simulations some of these issues. During the residency interview process, I was called shifty and aloof a couple of times. I had no idea why that happened, and that criticism never left my mind. I delved into studying auditory cognition and autism to find some way of deconstructing the deaf interview experience so we could learn from it. When you listen to this simulation of hearing with a cochlear implant, I want you to pretend that you're meeting with your program director or on an interview, or you're getting a performance review from someone above you. Recall the stress and anxiety that you feel as a hearing-capable person. And then with the simulations, imagine yourself as an implant recipient.
Life is for living.
So, who is that? Is that Stephen Hawking, or is that a female Darth Vader? Is this person sarcastic or funny? Where's the person from?
Life is for living.
The point is, during interviews, people tamp down their body language. So how do you rapidly tell from their voice whether someone thinks you'll be a great addition to the team, or if they're thinking about how your hearing might endanger patients? How do you do this on the fly by being witty, charming, and not being shifty and aloof? I want you to think about something else. The automaticity of hearing is crucial. Remember that you had to kind of mentally reach out and figure out what was being said in that simulation. That reaching out is key and is called cognitive load. One of my patients is a lawyer who lost his hearing later in life, and he actually gets to ceiling performance on some of the hardest performance measures on speech that we can throw at him. But if you ask him if he can negotiate a contract on behalf of his client with like 4 other people in a quiet room, he'll tell you I can't do it because I spend so much energy just trying to figure out what's being said that I can't think several steps ahead to negotiate the best possible outcome for my client. Now, the effect of hearing loss on cognitive load and executive functioning appears super obvious. But in the operating room, I was in completely uncharted territory as a resident. You all know that it's noisy, stressful, and people with hearing loss can't lip read because of the mask. So in training, I had to, when I hear, I have to parse out individual words, put into sentences, and then translate that sentence into an action with the hands, and learning anatomy, talking about cases. That becomes much harder. My staff thought that I was disengaged because I was quiet and not talking too much. And I had to train them and other colleagues over the years to let them know that I'm actually thinking quite a lot about what's going on and not to think that I'm being disengaged or shifty and aloof. So now that you've reimagined the problem, you can see this not just about hearing, but about giving the brain room to process what's being said and do the other function that it's designed to do. And one of these functions is to effectively connect with the other human being that you're talking to. Doing this effectively is hard enough for someone who lost their hearing later in life. But what about the 4-year-old kid? What about me? For those of us who grow up deaf and use degraded hearing of a cochlear implant to communicate, our entire social construct is built on interactions gleaned from a sphere of hearing that really only extends about 5 feet from our bodies. For normal hearing people, knowing what to say and when to say is conscious, but it's also instinctive and visceral, and it's guided by social neural circuits that are built by years upon years of just casual conversations, overhearing people in the hallway, and overhearing various conversations. These neural circuits are not as robust for people with hearing loss. So, how do we counsel people to deal with some of these issues? All of these things that I've described are well described in the literature, but we actually have no way of counseling patients. There are various auditory rehab programs that are very disparate. There's so much variability. The quality of the research isn't great. Bottom line is, if I have a patient with hearing loss, I can't tell them, if you do this on the job, your career performance and trajectory will be improved. If you do this with your loved one, spouse, family, friends, your relationships will be more fulfilling and you'll be less lonely. I have absolutely no way of doing any of this. So, most of the strategies that we use to rehabilitate people with hearing loss are more like receptive strategies. They're like, make sure the speaker is well lit, be in a quiet room. I mean, like, I've related to you so far how this is all very different than accommodating just cognitive processes. For example, when I learn something new, I always sit down because there's a cognitive load associated with standing. When I operate in the OR, I turn the lights down whenever I'm under a microscope or doing sinus surgery. Yeah, I can do it with the glare in the room just fine, but my brain is working harder. So these are very different strategies from the typical teaching people just to get the information. So some of the projects that I'm working on to address this, I'm going to skip down to the third point because this is where I'm talking out of order. So we're working with Johns Hopkins and University of Texas Southwestern to create a 5-bullet point list of how we can counsel patients. My other projects include basically everything is on hold for private practice right now, getting that started. But I also work on a signal coding strategy that we developed to improve cognition by improving the quality of sound with implants. And I work in a startup to help create some hearing assistive technology. So that's all I got. Any questions? Yes, sir.
That was a really nice talk. Is it true that the most common cause of congenital hearing loss is CMV infection? And does the etiology of the hearing loss affect the ability to do a cochlear implant? In other words, if you have a destruction of the cochlear nerve,
I would have to look back up the stat on CMV and congenital. Most of 60% of pediatric hearing loss is non-syndromic, 40% is syndromic or genetic. CMV itself does not alter the surgery. The only thing that really alters the surgery in terms of technique is if you have meningitis, you have to go rapidly from surgery to implant because you get ossification of the cochlea. If you have a patient who's ossified, you can drill out the basal turn of the electrode, or you can put it into the scala vestibuli, just depends. There are patients who have inner ear malformations, and you basically just shove it into a hole. I mean, there are some electrodes that you can use to get around some of these issues, but it's not generally a big problem.
Cochlear implant indicated in both sensory neural and conductive hearing loss?
Only sensory neural.
Only sensory
You can have, if you have conductive hearing loss that doesn't respond to a hearing aid, you can transmit vibrations to the bone of the skull in various ways and just directly stimulate the cochlea that way.
Thanks for your talk. When do you counsel patients for NF2 patients? When do you think is the best time to get them a cochlear implant?
NF2 patients typically are steered more towards auditory brainstem implants. The patients who have other acoustic aromas, not part of NF2, you can, it's an expanding category because previously we thought that the auditory nerve wouldn't get any stimulation from it. Now it seems like part of the hearing loss may be associated with proteins inside the cochlea that accumulate from disrupted flow from the acoustic schwannoma. So to answer your question again, it's basically still more towards ABI rather than implants. And ABI depends whether it's NF2 versus NF1 the outcomes.
Chad, how long does it take when somebody gets a cochlear implant for them to go through the cognitive training to know how to interpret those signals?
So we had a patient who got his implant, got it turned on, drives home from the clinic, calls the clinic, is like, "Yo, I don't think this is working too well. I mean, it just sounds absolutely awful." And all the audiologists are like, "You're talking on the phone on your first day." So it varies widely. So I think that most people can start to see improvement in about 3 months. The majority of those gains by about 9 months. 1 year will performance in quiet will asymptote, and then probably about 18 months speech and voice levels off, and then some people get some very, very few people get improvement past that. As far as cognition, I don't think that there's any cognitive training that really improves implants other than, I mean, yeah. There's like one exercise that helps, that is still an ongoing thing.
All right. Chad, thanks again.